Hey, good morning, Dr. A.
Good morning, Dr. Saylor.
Casey, how are you?
Good, how are you?
Hector.
Top of the morning, sir.
Thank you for being here. So, I'm Dr. Larry Saylor,
I'm Dr. Michelle Afonso.
and today we're going to do another subject. We'd like to talk about things that come up on a weekly basis. It's pretty easy to come up with material because every case is so different, and it's a nice time for those of you who like to do your research and who enjoy kind of taking charge of your health and understanding, as we like to say, we are not the old school in medicine, which is I'm the doctor, you do as I say. We like to bring you along for the journey and help you make,
Informed decisions.
yes, we make them together so that you feel like you're part of the process and that you're motivated to do something because it's in your
Best interest.
best interest. So today we're going to be talking about a neat scenario that came up. You want to tell us about the scenario?
Yeah, absolutely.
And we're going to be referring a lot to these photos, so Hector will give some nice images of what we're talking about. You want to put up the photo of how the patient presented?
Yes, absolutely. So our patient presented with a broken front tooth. This is a young man, and this is a case of actually a second opinion. We're the second opinion for this gentleman. So he came to us, and another dentist told him, well, that front tooth is broken in a way that it's not savable. So what we want to talk about today is when a case comes up like this, how can we evaluate a tooth and figure out, okay, can we save it?
Yeah, it's a big decision. Casey, what if somebody told you you're going to have to lose your front tooth? You would probably fight tooth and nail to keep it, and obviously this young man did a smart thing. Probably his gut instinct was telling him, I think it was actually his orthodontist who told him,
Yes.
you might want to check with somebody else. And yes, it's a big decision, and we do get these cases, and oftentimes we agree, and we have to tell the patient, unfortunately, the previous doctor was correct, but at least the patient
Has that peace of mind and has done his due diligence.
Yeah, and that's smart. You know, anybody should do that. So in this case, we'd like to talk about the information, the science, the data that would back up the decision on why we decided this tooth was savable. And maybe you can glean some ideas from this if you happen to be in this scenario or know somebody who is, or just the idea of looking at things from a perspective of breaking it down into risk factors.
Absolutely. We talk about risk factors a lot.
Yes, so we did decide to save it. I think we should go to the screen on some of the concepts and ideas of what made this savable. So now we're going to put our focus on the radiograph, which when you come in, that's the first thing I want to see, the photo and the radiograph in the history. And so we kind of know the history. Young man, he is actually going through orthodontics and
He's in his late 20s.
late 20s,
And
which
this
has
tooth,
something to do with ability to save it.
absolutely. Age is a very, very huge factor.
Yes.
Because in our practice, we're trying to get your teeth to 100.
Yes.
And so in his late 20s, with his tooth broken, a previous dentist, the other opinion, said that this tooth needs to come out and be replaced with an implant.
Right.
And
Which is a very predictable procedure.
Right. It's one of the best ways to replace a tooth. But again, knowing his age and thinking about different risk factors, it's kind of what we say in our office, like the ace in the deck that we want to kind of hold off.
Yeah, the ace in the hole that we try to hold off and use until we absolutely need it.
Right. So to look at this tooth and think, okay, let's see if we can hold off on doing the implant. What are the things we look at with the radiograph about saving the tooth?
Okay, so what's one good thing that he has going for him on this radiograph?
He's got a lot of bone around that tooth, and it's a pretty long tooth.
Pretty long tooth, that's good. Long tooth, good bone around it, and he has a decent amount of tooth above the level of the bone. We'll draw that in on the x-ray. We would like to have how many millimeters above?
At least 3.
Yeah, 3. I see 4 or 5 on the back side of that tooth and 3 on the front side of that tooth. And that's what we call a
ferrule.
ferrule, which is I think that's a term from engineering, and it's certainly a term that applies here, and dentistry is a lot of engineering.
Yes.
We're tooth engineers.
Yeah.
And so when we're looking at this, we have a long tooth, we have a ferrule, we have a tooth that is not periodontally involved, we have a young patient, and we also have a pretty thick tooth.
Yeah, it has a lot of good going for it in terms of strength and stability and predictability.
Yeah, so let's go back to the photo. So when you look at the photo, well, not that photo. Yeah, when you look at the photo, it's like, he doesn't have a lot of tooth there. But remember, this tooth is kind of like an iceberg, right?
Yeah, you don't see all of it from just the gum line. There's a lot hidden underneath.
There's a lot hidden underneath, and we already know what's under the hood because we've looked at the radiograph, and we know that we can picture what that looks like with the gum pulled back, which was what the radiograph showed us. And now we start to look at other clues, which does involve that other photo.
This photo shows the patient's occlusion, or the way that his teeth come together.
Yeah, so what clues do we get here that are not working in his favor?
Yeah, something he has against him is how much of the forces from the opposing tooth are hitting on that little lateral.
And that lateral we like to nickname
we call it the prima donna.
It's a prima donna. It is there for looks. It doesn't really want to work that much. So in this position we see here, we see the bottom tooth is in contact with our prima donna. We would like to see space there. And the worker tooth behind it,
the canine behind
which
it,
is like a guidepost, right? That tooth can take it on all day long. It's designed for it. So we have a little design flaw here, which is what we call high
functional risk.
high functional risk. And you can look at this patient, and we won't show his face, but look at the face, picture a jaw muscle that's really thick. Well, yeah, that's good. You can't see the patient. You see how thick those jaw muscles are. That is a sign right away that's highly correlated with high functional risk. In fact, a lot of times we'll be sitting there talking to the patient, and those muscles will be flexing like I'm flexing my bicep right now. Well, it's not as big as it used to be. But you get the idea. That flexing of that muscle, he can't help himself. He's kind of built that way, and he's also exercising those muscles. And so we know that's a high functional risk, and we can kind of look at some of the other clues. When we look at his teeth, he goes there a lot. There's wear on those teeth. And you see the wear on the teeth, and the good thing is he's already going through orthodontics, I think, to probably address this issue with, another doctor. And then some of the other things he has going against him, what we talk about, the domino effect, is he's missing some teeth. Missing some teeth on the top and bottom, which puts more load on the front teeth where it shouldn't be. So we have to change those things. Like we say, he's already in orthodontics, so we can continue with that and get the forces in the right place. Let's go back to the other photo. What's another thing that we could do to help it?
Get the worker tooth, the one that can take on the force of the canine, build that back up to how it should be.
Yeah, put a little bit more of a cuss tip on it, because sometimes patients will do that. If they're used to it being flat, they go, it looks like a vampire tooth. It kind of has a point on it for a reason, Casey. I mean, that is doing it's there for design to do its job to get the load off the prima donna tooth. And then the other thing that we can do is take that lower tooth that's actually higher than the ones besides it and take it down a little bit. And that's something that we always talk to the patient about, because if we do that and we don't talk to you about it, you're like, what? Why are you grinding my tooth down? I'm coming in for the top tooth, you're grinding on the bottom tooth.
Right.
It's all in an effort to try to get the risk mitigated and decrease that functional risk so we can have a better success ratio on this tooth that we're going to build back. And so we can take that lower tooth down a little bit, which when we look at it, it needs it anyway because it's propped up.
Right.
And so that's the way we look at this. It's not just a knee-jerk decision. We want to be the hero, and we are going to fix your tooth, because if we did that and the tooth failed in 3 weeks, we wouldn't keep doing that.
And we'd be feeling pretty down about
Yes. We'd be walking to the office like, gee, how many calls did I get today with my hero dentistry that's failed? Which is not the case, because we are very careful about, the decision on your behalf in your best interest to do something like this and to invest the money, because after all, what would be the value in being able to keep this tooth versus an implant?
It's kind of that time span throughout your life of, if anything were to happen to this tooth in the future, let's say when you're in your late 50s, 60s, then you can do the implant.
Yes, then you could do the implant. And being able to forego that surgery now saves you not only time and money, because the implant takes a long time, and a lot of extra money. Also, if you did an implant right now, and this is a subject for another video, over time that tooth is not going to look like the other teeth.
That's
It
right.
stays fixed in time where your face keeps developing. So those are all the reasons that went into saving this tooth, and also talks about a lot of the details on how, once we do restore the tooth, what we can do in order to have better success with adjusting the adjacent tooth, talking with the orthodontist and telling him some of the design features that you would like in order to get the tooth out of harm's way, get him what we call anterior guidance. And then on a bigger issue, some of the work that can be done to decrease some of the hypertrophy of these muscles, and also the very basic thing of putting him in a bite guard. But in this case, he's going to be in a retainer anyway, which is going to be fantastic, because I like to say with a retainer, it's like
putting your nice car in a garage.
Yes. It's like putting a nice car in the garage at night. So if you bought a Ferrari, or let's just say a nice BMW, Mercedes, or something like that, a car that is new, you're going to want to put it in the garage. If you want to protect your nice teeth, put them in a garage at night.
Yeah, wear that retainer.
Wear that retainer or bite guard. So let's look at some other photos and just pick up on any other little nuances that we may have not talked about.
Once you kind of look at, okay, the tooth has enough ferrule. It's periodontally stable, meaning it doesn't have a lot of bone loss or periodontal disease around it. Good bone, and we've tackled and mitigated the risk with the occlusion. When you're choosing, okay, well, how am I going to fix this tooth? What are we going to do? How do we actually save it?
Yes. So you can do a crown, or you can do a BioClear restoration here. And in this case, and I can't actually remember which way we decided to do, but you go with either. And if you did a BioClear restoration, you have the benefit of not being able to take away any more tooth structure and add to it, but you can't take advantage of the ferrule as much. So in this case, I would opt for a crown.
Exactly, which we'll show the diagram on that. And help with the stability of this tooth, even though we are taking the load off of it, being careful with the way that the teeth are hitting. Again, that crown is what's going to take advantage of that. And in addition, the post, I think we should talk about the post.
Yeah, so the post has to be designed properly as well. That post should go 3/4 of the way down the tooth. So when you put the post in there, and we have this discussion with the patient, because we can have these technical discussions with the patients that they like, the patient will look at that and say, oh yeah, that's down in there. Because you can see where the post ends, right? And that post ends just a little bit more down than half the tooth, right? And the diameter of that post should fill that space, but you're not going to want to create a bigger space to accommodate a bigger post, because this post, where it ends, shouldn't make up more than half the diameter of that tooth. So that post there's a design aspect to the post. There's a certain size of the post that we use. There's the length of the post that we use. And there's a proper cementation of that post that we use. And now you can picture that post as being like a piece of rebar or something that reinforces concrete. And that's exactly what this does. And another little nuance in his case is he was going through orthodontics. So what we asked is, let's go ahead and restore it in the meantime with a BioClear. And now, while he's going through the orthodontics, let's have the orthodontist erupt the tooth a little bit more, which gets us more
Of a ferrule.
of a ferrule. And then we can go ahead and complete it, which we just have. and now he came back and we finished it with a crown. So we're doing everything in our power to make this tooth successful. In other words, we're using our brain
And our toolbox.
and our skills and techniques. And the nice thing is about working with an associate that's on the same page is we're using two brains.
Yes, that's right.
So those little things add a nice value proposition for you if you choose to go down this road. Now let's go back to the other photo, and then I think we'll end with this because I think that we have discussed this situation and it goes through a lot of points. There was the other photo of the review of the upper and lower arch. Yeah. There's another little clue here on further steps to take down the road.
The teeth that are missing.
Yeah, she knows exactly.
Well, having a good mentor and thinking these things through together helps so much.
So look at this.
here.
What do we
Yeah.
see there?
He's missing a space. He's missing one of the key teeth to help with his chewing forces.
And what tooth is
up on
that?
the back. That's your 6-year molar.
Your 6-year molar. So we always say to get you to 100, we want 6-year molar and forward. It'd be a bonus if you have your 12-year molar. In this case, I would like the 12-year molar because of what? He has high functional risk.
Yeah, I had to think for a second, but yeah, the high functional.
He has high functional risk, so we would like a 12-year molar. For Casey, we may not need it, right?
Right, because she doesn't have.
She's going to have it anyway. But
She'll have her 12-year molar, but yeah, looking at an individual's risk profile.
yeah, it's like in her case, we may be like, you know what? You don't need to spend the extra money to get back the 12-year molar. For this gentleman, we would want him to do that because, again, when we look at the masseter, yeah, I'd like a 12-year molar there. So we would want 2 implants there. And again, I hesitate to say we would want 2 implants because we're making that decision based on what's in his best interest. We always do.
Right.
Because the patient doesn't want 2 implants, but they may need 2 implants in order to get to 100 with all their teeth. So that can be overwhelming a lot of times. We're like, yeah, do this, do that. So we always say, let's take one step at a time, but that is what we're thinking.
Yeah, and we kind of plant the seeds so that you can understand what we're seeing and what we are trying to kind of predict as to what could be beneficial to get you again to 100 with all your teeth with, in his case, implant supplementation.
Yeah, titanium supplementation.
Titanium, that's what you say, yes.
So we like to say we're going to get you to 100 with all your teeth, but it may take a titanium supplementation.
Exactly.
So that's fantastic. I mean, look how much you can tell with one photo. And I have always said that I can't wait for the day. And I said this the first day when I was doing exams in dental school because I didn't see anything. All I saw were teeth, and I had no idea the story that they would tell me. Believe me now, and this is what you would want a professional to do, and this is what I want professionals to do that I work with, is when they're speaking with you, because a lot of times you ask their decision, they're like, I don't know, you tell me. And I'm like, you're the professional. I would expect you to have some insight into what you see, and we do have a lot of insight, but we're still careful to bulldoze over decision because we'd like to help you make that informed decision. And that's our MO. If that makes sense to you as an individual, then we would be a great practice for you. If you're not so much into that style of making a decision, then at least you already know we may not be a good decision or good practice for you.
Right. We want to be your resource, but we are very good at communicating, hence all the photos, and talking through these very important aspects to look at. And so we want to be your resource, but it's ultimately a decision that you will make together with your dentist.
Well said. Thank you.